Naveena Saseendran, talking on Ectropion and entropion, getting the lid straight. So she is the assistant professor of ophthalmology at Alappuzha Medical College. Welcome, ma'am.
Good morning, everyone. First of all, I would like to thank Dr. Shebin for giving me this opportunity. So today my topic is entropion and ectropion, getting the lid straight. Okay. So, first of all, what are the anatomical factors that are keeping our lid straight? They are the horizontal attachments by the medial and lateral canthal tendons, and the vertical and anteroposterior forces exerted by the orbicularis muscle and the retractors of the lid, which will keep the tarsal plate straight. So, entropion is inward turning of the lid margin. So, what is the main pathophysiology behind entropion? Here, there is laxity of both medial and lateral canthal tendon, which will result in loss of horizontal support. Also, overriding of preseptal muscle over the pretarsal orbicularis. Here, you can see the lax lower lid retractor, which causes outward turning of the lower border of the tarsal plate, and also the atrophy of the tarsal plate leading to inward turning of the upper border of tarsal plate. So the lid can turn either in or out depending upon the changes in the orbicularis, lower lid retractors or tarsal plate. Coming to classification of entropion, it can be congenital, involutional, which is the most common type, then cicatricial and spastic. So what brings the patient to the ophthalmologist? It is a foreign body sensation, redness and watering, and these are secondary to corneal irritation by the lash or the keratinous conjunctiva. How to evaluate these patients? We have tests for horizontal laxity such as pinch test, snapback test and horizontal distraction test. So here in pinch test, we are pulling the lid away from the globe and we are assessing how far we can pull the lid away from the globe. So if it is lax, it will be, we can pull it, if it is more than 6 millimeter, it is considered as horizontal lid laxity. Then snapback test. Here we are pulling the lid downwards and slowly releasing it. So in normal cases it will immediately snap back, but delayed in case of horizontal lid laxity. Medial canthal tendon laxity. Here we are assessing the degree of punctal displacement by giving a lateral traction to the lower lid, whether it is coming up to the medial limbus or up to the pupil. Lateral canthal tendon laxity, you have to note the rounding of lateral canthal tendon. Then the test for lower lid retractors, we have to ask the patient to look down and see for the lower lid excursion. Normally it will move around 4 millimeters. In case of retractor laxity, it won't move. And also we can notice a white subconjunctival line of detached retractors in the inferior fornix. Ask the patient to squeeze and release to test for orbicularis muscle. Now coming to management of involutional entropion, it can be temporary methods or permanent procedures. Temporary methods include sutures, taping and botox, and permanent procedures will be dealt in detail. So temporary sutures can be either transverse or reverting sutures. So both will prevent overriding of preseptal muscle over pretarsal orbicularis, and these are mainly indicated in geriatric patients and patients having bleeding disorder. In transverse suture, the bite is taken from the conjunctival side just below the tarsal plate and it passes transversely and emerges at the skin side. And it is useful in case of spastic entropion. And in everting sutures, here it will take care of the lower lid retractors and also it will transfer the pull to the upper border of tarsal plate. If entropion is not associated with any horizontal laxity, then we have V's procedure. Here the full thickness lid split is given transversely, which will create a fibrous scar that prevents the overriding. It is combined with everting suture, which will transfer the pull to the upper border of the tarsal plate. If entropion is associated with lid laxity, then a horizontal lid shortening is also indicated. So the above V's procedure can be combined with horizontal lid shortening, that is Quickert procedure. Now, in case of recurrence or retractile laxity per se, we have Jones procedure. Here, we will take care of the retractors. We will plicate and shorten the retractor, and also the fibrous scar will prevent overriding. So this is summary of involutional entropion. If we are not having any horizontal laxity, we can either go for a temporary method or a permanent procedure. If we have horizontal laxity, a Q-cut procedure can be done. If there is recurrence, Jones is advocated. Now coming to cicatricial entropion. Cicatricial entropion, the main pathology lies in the posterior lamellae, that is the tarsal plate and the conjunctiva. So in case of lower lid cicatricial entropion, here we are assessing the lower lid retraction below the limbus. If it is less than 1.5 mm, it is considered as mild, and if it is more than 1.5 mm, it is severe. So in mild cases, we can do tarsal fracture and everting suture, and in severe cases, we need a posterior lamellar lengthening using a graft. Upper lid cicatricial entropion, the management depends upon the severity of the entropion, the tarsal plate thickness, the keratinization of conjunctiva, and lid retraction. So if it is mild, we can go for anterior lamellar repositioning, where the anterior lamellae is sutured high up in the tarsal plate. And if it is severe, depending upon the tarsal plate thickness, we can have tarsal wedge resection if the tarsal plate is thick, as in case of trachoma, and posterior lamellar division and graft placement, as in case of thin tarsal plate in ocular pemphigoid and Stevens-Johnson syndrome. In case of keratinized tarsal conjunctiva, you can rotate the terminal tarsus outwards, which will prevent the corneal irritation. If it is severe lid retraction, then a posterior lamellar graft is indicated. Now coming to spastic entropion, which is secondary to mainly inflammatory diseases of eye or any recent ocular surgery, and the treatment is taping of lids or Botox injection. Congenital entropion, always roll out epiblepharon before going for any surgical intervention. In epiblepharon, there is no actual inward turning of the lid margin. Congenital entropion can be managed by Holt's procedure. Here, an ellipse of skin and orbicularis is removed just below the punctal area, and the lower lid retractors are sutured to the lower end of tarsal plate. Now coming to ectropion. Ectropion is outward turning of the lid margin. The symptoms are similar to entropion, like redness and watering, and there will be inability to close eyes, and there will be associated features of facial nerve palsy if it is a paralytic ectropion. And these features are secondary to corneal exposure, tearing, and keratinization of conjunctiva. Ectropion can be classified as congenital, which is rare, and acute can be involutional, paralytic, cicatricial, and mechanical. So management of ectropion should address the following 6 pathological elements. Now management is mainly based on the segment of the eyelid involved. So it can be generalized ectropion or medial ectropion or lateral ectropion. In case of generalized ectropion with horizontal laxity, a horizontal lid shortening is indicated. Here a pentagon shaped lid margin is excised and sutured directly. It can be also managed by another procedure known as lateral tarsal strip. Here a full thickness incision is given at the lateral canthal area, an inferior cantholysis is done, and a lateral tarsal strip is fashioned out, removing the anterior lamellae and the posterior conjunctiva, and this strip is attached to the pediosteum. So the advantage over horizontal lid shortening is that there is no sutures over the lid margin. Now if ectropion is associated with horizontal lid laxity and excess skin, then this excess skin muscle flap has to be removed by Kuhn-Siemnowski procedure, in which we will do a horizontal lid shortening and blepharoplasty. Now medial ectropion can be either punctal eversion alone, or it can be associated with medial horizontal laxity, or it can be medial canthal tendon laxity. If it is a punctal eversion alone, it can be managed by excising a diamond shaped tarsoconjunctiva below the punctum and suture it vertically, which will invert the lid. So thereby we are shortening the medial posterior lamellae. If it is associated with medial horizontal laxity, a lacy procedure is indicated where we will do horizontal shortening at the medial end. In medial canthal tendon plication, the medial tarsal plate is identified and it is sutured to the medial canthal tendon insertion. Coming to paralytic ectropion, it can be managed by either temporary or permanent methods. Temporary includes taping of the lid, lubricants, and permanent includes lateral tarsorrhaphy. And another method is medial canthoplasty. Here, raw area is created medial to punctum in both upper and lower lid, and it is sutured directly, taking care of the canaliculus. Lateral canthal tendon laxity can be managed by lateral tarsal strip, as explained before. Cicatricial ectropion, the main pathology lies in the anterior lamellae. So, if it is a local linear scar, we can go for resetplasty, where two skin flaps are transposed to increase the length of the skin along the scar line. In diffuse scar, we can go for either skin flap or skin graft. In case of skin graft, full thickness skin grafts are preferable. Mechanical ectropion always remove the cause and treat any associated laxity. So to summarize, in case of involutional entropion, if it is medial, punctal eversion alone, you can do medial conjunctivoplasty. If it is associated with horizontal laxity, lacy procedure is advocated. Generalized ectropion, it can be managed by horizontal lid shortening or lateral tarsal strip. And in case of lateral ectropion, lateral tarsal strip alone. And in paralytic ectropion, you can go for medial canthoplasty or lateral tarsorrhaphy. Cicatricial, depending upon the type of the scar, you can manage. And mechanical ectropion, treat the cause. So, to conclude, knowledge of basic anatomy and proper counseling is essential for the best results. Thank you.
Thank you, ma'am. Thank you for that elaborate discussion on entropion and ectropion. Next,